You're welcome to the Rainbow Push Convention virtual this year. We have outstanding participants and speakers who will address us. 5 critical issues in our convention we dealt with. Number 1, the issue of Trump misleading people. Fact of the matter is that he's said American against American. January 6th was an act of treason and terror. A rebellion against our government, attempt to overthrow our government, attempt to kill the vice president, kill the speaker of the House. We deserve better than that. Trump has been a bad force for people in America. And he made people angry when they should be cooling out the anger that might be meaningful people. So we know that the misleading statements of Trump about John McCain, 7-year veteran who served in the war, 7 years a prisoner of war. Couldn't left early because of family contacts. He chose to suffer for the people. Yet Trump had draft dodge attacked John McCain. It's not right. So we'll talk about that this year. Also, the impact of the pandemic. We left it too quick. 1/3 of America is not vaccinated. Vaccination will lead to extermination. You must choose to vaccinate or you'll die. There's a new Delta variation coming right now. Those who have been diagnosed, who have vaccinated, may get sick but not in the hospital, not die. Odds are in our favor. Please get the vaccination today, wherever you are. Don't wait another moment. Thirdly, we'll focus a lot about education. Strong minds break strong chains. Our children, we're teaching them to learn, to love learning. What we've done, for example, we have an academic athletic program where kids want to play basketball. They STEM in the morning. No STEM, no basketball. That's the size of our time. So we're making them relevant. We have $25,000 scholarships from Toyota for our children. We need you to be a part of the convention. Sit back this week and watch it. A, get involved. B, register and vote. C, let's march until we get the Voting Rights Act passed this year. One thing is the Voting Rights Act does not pass this year. Democracy will lose, Democrats will lose, and the nation will lose. So Democrats beware. We're bound together. If blacks cannot vote, whites cannot win. Progressive whites, women cannot win. We need each other. So let us march together and fight together until we have a bill that makes sense for everybody. God bless you, and let's have a good time at the convention. Let's think it through, and then if it's over, let's act together. Thank you very much.
One of the most critical pandemics that we face in the world today is this pandemic of COVID-19. And it continues to hit us in many different ways. Some people have become vaccinated, some people are following protocols, and many are not. And so what we're doing at the PUSH Convention, we're giving you an update from Dr. Fauci and Dr. Zeke Emanuel, and then we have a roundtable to look at where we are in terms of healthcare. What COVID has exposed is the glaring disparities in access to qualified healthcare, affordable healthcare. We now know who is left out of the healthcare system. And so as you watch these discussions and as you listen to Dr. Fauci, one of the things I want you to do is to decide how you can be a part of this growing population and make sure that healthcare is available to everyone, make sure that everyone has taken the appropriate steps to prevent the spread of the vaccine. And now let's listen to Dr. Fauci and Dr. Zeke Emanuel and then our panel.
Let's be honest, Blacks, Hispanics, other minorities have always been at a disadvantage when it comes to healthcare. They have lower rates of insurance, higher rates of diabetes, hypertension, and other illnesses, and they have higher rates of death from heart disease and cancer. And the result is a much lower life expectancy. COVID has only exacerbated these disparities. Black people have 2.9 times more hospitalizations and 2 times more deaths than whites. And Hispanics the same, 2.8 times more hospitalizations and 2.3 times more deaths. And as a result, just during COVID, the difference in life expectancy has expanded to 6 years between whites and blacks. And now we have great disparities in vaccination rates and use of vaccines. Globally, over 3.5 billion COVID vaccine doses have been administered to people, more than almost any other vaccine, certainly any other vaccine in just less than a year. By mid-July, 59% of American adults have been fully vaccinated, and over 68% of American adults have received at least one dose of the vaccine. These vaccines are very, very safe with few long-term effects. The mRNA in the Pfizer and Moderna vaccines, it's totally destroyed in 48 hours. It's not in the body affecting any organ, whether ovaries, fertility, in the DNA. It's totally gone. There are some fundamental disparities in vaccination rates. Rural areas have fewer vaccinated people. So we've got low vaccination rates in places like Mississippi, Arkansas, rural Missouri. African Americans make up 9% of those who have received one dose, and yet 12% of the population, down by a third. We know that we have big disparities. We need to make progress. There are 4 important barriers to getting people vaccinated: disinformation, access issues, financial issues, and attitudinal issues. Let's talk about each of them. Disinformation. Some people say that COVID vaccine will give you COVID itself. False. Some people say COVID vaccine will be incorporated into your DNA. False. Some people say COVID vaccine will make you infertile. False. Vaccines have not been well tested in children. Also false. Thousands upon thousands of children, tens of thousands of children have gotten the vaccine. Some say COVID vaccines will cost you money. Also false. All of these are false. As I said, no major problems with the vaccines. We've had a few small problems, but they are safe, more safe than any previous vaccines overall. What about the access barriers? Well, right now, there's more than enough vaccine. You can walk into almost any pharmacy in the United States. You can go to Costco and CVS, Jewel Osco, Rite Aid, Kroger, Harris Teeter, Stop and Shop, Giant, Walgreens, Walmart, and get a vaccine and choose which vaccine you get. These pharmacies have given over 100 million doses. You can walk right into them without an appointment. You can also go to federally qualified health clinics and get a vaccine. Financial barriers. The COVID vaccine is free. Free. It's a great deal. Is free not cheap enough? But people need to know they're free, and you need to emphasize that. No one pays a penny for it. And if you're paying a penny for it, there's a scam going on. Now, we also know that employers need to do what they can do. They need to help workers get time off, and the day after the vaccine, when they might be feeling side effects of fever or fatigue, that they can take that day off without losing pay. It's really important. Many people have yet to get the vaccine because it's not convenient, or so they say. Vaccination sites are far. Signing up for an appointment is complicated. As I mentioned, just go to a pharmacy. The government's making it easier to get a vaccine by walking into pharmacies, having mobile vaccine sites, and going door to door to reduce the barriers. You can also go to your doctor. So it should be easy. If you're an employer, you can get your workers vaccinated. Bring the vaccine to your workplace. Make vaccinations open to the workers and their family members. Give workers, as I said, the day off after they're vaccinated with pay in case they get some side effects. This could boost vaccination among your workers, keep them healthy, and keep things productive for your workplace. Schools also could reduce the access issues. They're a key place where we could improve vaccine uptake through education, clinics, and giving children vaccine and their parents in the school. The last issue are attitudes. We have to get people who've been vaccinated out to convince their fellow community members that the vaccine is safe. Yes, they might have had a sore arm. They might have had some sleepiness and feeling punk, but they bounce back and they're fine. Nothing serious has happened to them. We should also communicate that we didn't pay for the vaccine. It was free. We've got to remove these attitudinal barriers to getting the vaccine. Getting the vaccine is really important to staying healthy, really important to not landing in the hospital, and certainly not dying from COVID. As I mentioned, there are 4 major barriers. Disinformation, all those false claims that it affects fertility or it gets into your DNA or it costs money. None of them are true. There's the financial barrier. People think that they'll have to pay for the vaccine, but they don't have to pay. It's free. There's access barriers. Where do I go? Go to your local pharmacy, your Jewel, your CVS, your Walgreens, your Walmart. They'll give you the vaccine and you'll choose which one you want. And then there's the attitude. You should emphasize how safe the vaccines are, other people who've gotten it so that they can talk to people who've gotten it, and talk to employers so that employers can make it easy for people to get the vaccine. Look, beating COVID is really important, and getting the vaccine is the key way to beat COVID. It allows all of us to get back to our normal life without a mask, with family, and with safety. Thanks, and please go out and get vaccinated. Convince your family and friends to get vaccinated.
Greetings. My name is Tony Fauci, and I am pleased to speak with you today at the Rainbow Push Coalition Annual Convention. As you can see from my title slide, I've chosen as the subject of my discussion emerging infectious diseases, past as prologue. And let me explain what I mean by that. This is a map of the world that I have used at a number of appearances and briefings and testimonies that I've done before the United States Congress, with the purpose in mind of pointing out the importance of emerging and re-emerging infectious diseases. I actually started doing that 37 years ago when I first became director of the National Institute of Allergy and Infectious Diseases. And I showed the map because I wanted to show at the time in the early 1980s that HIV was a dominant and very transforming emerging infectious disease that was really a new disease known to mankind. Over the 37 years since, each year, when I testify before the Congress, I point out that there's maybe 1, 2, and sometimes 3 new infectious diseases that emerge. And to just give you an example of what has transpired over the past 37 years, the last time I testified before the Congress just a month or so ago, this is what that slide looked like. Now, some of these emerging infections that are on this slide are curiosities which don't have a global impact. But as we now know, several of them have had a substantial and sometimes transforming impact. And in fact, one of these is one that we're living through right now, the COVID-19 pandemic. In the very early month of the pandemic, I wrote an editorial in the Journal of the American Medical Association when we were describing the first cases of COVID-19. And the title of my viewpoint was Coronavirus Infections More Than Just the Common Cold. And I wasn't trying to be facetious by that title. I was trying to get the readers of the viewpoint to appreciate that we've had experience with coronaviruses for decades and decades, but things can change even within the family of a given pathogen. So this is the phylogenetic tree of coronaviruses. The viruses that infect humans are in red font, and the 4 viruses that are yellow highlighted are actually the viruses that account for anywhere between 10 and 25% of the common colds, which are generally benign and which we get recurrently infected with year after year. However, as the situation emerged in 2002, we had the first pandemic of a coronavirus, the severe acute respiratory syndrome, or SARS, which began from a reservoir in a bat to an intermediate host, likely a civet cat, to humans, leading to an outbreak of 8,000 cases and almost 800 deaths. In 2012, we had another somewhat muted pandemic of a coronavirus called the Middle East Respiratory Syndrome, which arose in Saudi Arabia. But again, the connection between a bat, an intermediate host, the camel, and a human. And these are the two viruses here now, the pandemic viruses on the phylogenetic tree. But now we're facing with one of the most historic pandemic outbreaks that we've ever experienced on this planet. Certainly nothing like this in the last 100 years. And that is the new SARS-CoV-2 or COVID-19 pandemic. And here in the yellow highlight is where that virus fits in on the phylogenetic tree. So let's take a look at what the results of this outbreak have been. Throughout the world, there have been almost 190 million cases and more than 4 million deaths. The United States has been hit as hard or more hard than any other country in the world. Between the United States and Brazil and India, we are within the top few, with over 33 million cases and now, tragically, over 600,000 deaths. The NIH research agenda directed at COVID-19 is multifaceted, involving therapeutics, diagnostics, natural history, basic research, but importantly, vaccines is one of the critical issues. And indeed, this has been a resounding success story. The story behind how we got so successful with these vaccines is not something that began, in January of 2020, when we first became aware of this new virus. As I said in this editorial, the speed and efficiency with which these highly efficacious vaccines were developed and their potential for saving millions of lives are due to an extraordinary multidisciplinary effort involving basic preclinical and clinical science that has been underway out of the spotlight, under the radar screen, literally for decades before the unfolding of the COVID-19 pandemic. And in fact, this timeline shows that on January 10th, on the far left, when the virus was sequenced, within a few days, we went into GMP production with Moderna for an mRNA vaccine. And within 65 days, we were in a phase 1 trial. And then all the way to the right-hand part of the slide, in less than a year, namely 11 months, we actually had a vaccine that was safe and highly effective, leading to an emergency use authorization in December. The vaccines are highly efficacious to 93, 94, 95% in clinical trials. They're even more impressive in their effectiveness in the real world settings. And indeed, they have been shown to be quite safe. And this is a display of the selected vaccines for which have already been approved, namely the 2 Moderna and Pfizer mRNAs, the J&J adenovector, and others that are in the process of being developed, such as the AstraZeneca chimp vector, the chimp adenovector, and the 2 recombinant proteins and adjuvants with Sanofi and Novavax. And so in conclusion, what we're dealing with right now is literally a metaphorical race between the SARS-CoV-2 virus, which continues to evolve variants, the most recent of which is the Delta variant, which has a much higher degree of transmissibility than the prototype virus, and our ability and our capability of vaccinating individuals with our highly effective vaccines. And I don't mean only in the United States, but ultimately worldwide, because this is a global pandemic that will require a global response. And we must fully implement and utilize the most extraordinarily effective tool that we have, and that is our highly effective vaccines. Thank you.
For 2021, we're excited to get more people engaged and involved in Rainbow Push, supporting the programs of Push for Excellence and the Citizenship Education Fund. Now, if you're interested in public policy and you want to help change the policies that impact those who are incarcerated, you can do so. If you're interested in impacting public policies that benefit education and businesses with social economic solutions, you can do that as well. You can become a policymaker by becoming a member of Rainbow Push right now. Now, if you believe in the scholarships that we've given to thousands of students each year, you can help us out. We've awarded more than $10 million in scholarships year to date. Now, you can help young people achieve a higher education by becoming a member of Rainbow Push right now for the annual fee of only $35. And if you're a student or a senior, it's only $15. You can help us make a difference in the lives of millions. Now, if you watch us every week, or if you listen to us on the radio, or if you're viewing on social media, we need you to become a member. And how do you become a member? It's simple. Visit us at rainbowpush.org and press join. Maybe you'd like to support the work of Push. If so, it's really simple. You can do so by texting the word PUSH, that's P-U-S-H, to 41444 on your cell phone, and you can give any amount that you feel comfortable giving, or you can call us at 773-256-2775 or go to rainbowpush.org and push donate. So whenever you want to support, you can do it from anywhere. So keep pushing, because we're going to keep pushing for you and keep hope alive.
Hello, everyone, and welcome to Rainbow Push's Health Equities Summit. We have gathered some leading medical as well as health experts to talk about the impact of health equities. My name is Daryl Denard. I am the news anchor as well as host and producer of iHeartRadio Chicago's community affairs programs, Chicago Speaks, as well as Chicago Insight. And they air, of course, on V103 as well as WGCI and also Inspiration 1390. I've had the pleasure over the years to interview many of our panelists today, but I'm going to introduce them to you. We are going to begin first with our Congresswoman for the 2nd District, if I'm not mistaken there. And that is Congresswoman Robin Kelly, and she joins us from Washington, D.C. We also have Dr. Jeffrey Sterling with Sterling Initiatives, as well as Dr. Deborah Fuhr-Holden. She is an epidemiologist and professor of public health, as well as Rosalind Carpenter, who is with the Black Directors Health Equity Association, and Dr. Lashmi Emery, who is the Chief Medical Officer for Aetna Better Health of Illinois. Welcome all of you to the panel. We're dealing with health inequities and really trying to get a firm grasp in terms of what exactly is a health inequity and why is it so important, especially for people of color. I want to begin first with you because of your work that you do on the health committees in Congress there, Congresswoman Kelly. And if you were to give your definition of health inequities, what would they be?
Wow, you asked me before the MD. Well, I think health inequities, I guess I look at the inequities in health outcome, inequities in the lack of access to healthcare, the lack of diversity among healthcare providers, the lack of culturally competent care. I think, all of those are inequities, or what describes inequities is systemic. It's not just one thing or another, but it's systemic.
Dr. Sterling, what would you add to that definition that Congresswoman Kelly just gave?
First off, I want to commend whoever came up with the question. We tend to speak in terms of healthcare disparities, which really just implies a difference in outcomes. The key point about inequities is that there's an implication of unfairness. So there's actually a judgment attached to it. And as such, we should actually be looking at the infrastructures of our healthcare and public health systems. And doing so allows us to address structural and institutional racism. So until and unless this is done, all we really are doing is playing whack-a-mole whenever the disease of the day pops up, because we haven't really dealt with the institutional components, which predictably produce the types of things like we've seen in COVID-19 that we then call healthcare disparities and get all upset about. So you kind of have to remember there's a difference between disparities and inequity, and have to get to the root causes in order to be really effective.
And how are those inequities as well as disparities played out in light of COVID-19, Dr. Verholden?
What we've seen during COVID is, I always say COVID is the snitch. COVID didn't do anything besides tell the truth on a lot of our problems. So many of the inequities that we had, and I love the way that Representative Kelly and Dr. Sterling framed it, we've got the disparities, the differences that we see downstream. But if you go downstream and look at those differences, and you look further upstream, you understand the systems and the structures and the policies that gave rise to all of those disparities that we saw downstream. So what COVID did is put us in a state of emergency, and all of the gaps and cracks in our system of care, the light got shined on them during COVID. So COVID told the story on us. COVID snitched on our healthcare system. COVID snitched on our, institutions and structures.
It's interesting because, Ms. Carpenter, equity and health equity is in the title of your organization. So I'm sure that it plays a big role. So how do you see the two intersecting as well as being different in terms of equity as well as disparity?
Well, thank you so much for the question, and thank you for having us here today. Everyone has the right to be healthy. It should not be considered a luxury or a privilege to be able to access healthcare or live in a community where conditions support better health. And for the health and well-being of our society, eyes can simply no longer be closed, heads cannot be turned, blame cannot be shifted. This is the time for all people to demand justice, dignity, truth, and health for all. And COVID, as just shared, has illuminated for us what we've known to be true for Black and Brown communities for decades. Health inequities are widespread. We live sicker and die sooner than all other vulnerable and disenfranchised populations. Now, health systems are anchors in our communities, but we cannot do it alone to change health outcomes. Partnerships and collaborations are essential, which is why BDHEA exists, the Black Directors Health Equity Agenda. And we're working to help solve and eliminate health inequities.
And speaking of health disparities, Dr. Emery, we see them played out, you see them played out on a daily basis in terms of your role as medical director with Aetna and Aetna, Illinois. And the reality is that many times we see them played out, particularly as we age and become eligible for guaranteed health in these United States of America. Why is it that we seem so reticent about dealing with not only the disparities, but also the inequities until we get it at an age where the diseases become even more compounded?
Well, and you bring up a good point about chronic diseases. So these are diseases that have been left untreated or undetected or undiagnosed for decades sometimes. And it all boils down to health inequities again. I think it's really important that we understand the difference between the term inequality and inequity, because they're sort of intertwined, but they are different. So in terms of inequality, that's where we have differences in the health status of populations in a demographic. And so, as you pointed out, especially in African American communities and communities of color, we often see that people have chronic conditions that go into later life that may end up being the terminal diagnosis, being the thing that kills them, or be something that really affects their quality of life, for decades. In terms of inequality, that's where we have these inequities that are socially produced, they're systemic, and they have unequal distribution across the population. They're avoidable, they're unfair, and they're unjust. And that's a point that I think a lot of people have brought up, that these are really social constructs. Inequities are socially constructed. And so we need to look at integration in health equity considerations, lenses to policies, to programs, to collaborations with other sectors. So health, legal, political, as we have represented here. We all need to work together to address these inequities. None of us can do it alone. We also need to engage the communities that we're trying to support in their efforts to address inequities. And we do that in many ways at the health plan on a daily basis across the board.
One reality in terms of a positive note that COVID has pulled the curtains back is not only inequity as well as disparity, but also the need for funding there. Congress took a rather aggressive approach to funding programs to deal with these disparities, particularly in light, Congresswoman Kelly, in terms of just the initial impact of the disease disproportionately affecting people of color, especially Black folks.
Definitely, we have worked really hard through various bills to bring resources, money, tools to communities disproportionately affected. What we just passed, the American Rescue Plan, was another way for us to, give back, to make sure not only that people are getting tested, but people are getting the vaccines, everything's free, 160 billion to schools so they could make sure they're ready to reopen. Of course, that was before the resurgence with the Delta variant, but just different things we've done throughout the United States. But the issue is that we have worked really hard. And of course, there's always more to do, but we can't make people take the vaccine. That the public has a role to play, in this also. And there's still too many people, for whatever their reasons are, that haven't taken the vaccine or got one and didn't get the other. But we have worked really hard, and we're doing appropriations this week, and there's more money through these appropriations to help people not only survive through this, but businesses and parents with childcare and all of that to thrive and to be better than they were before.
Yeah, and it's tragic because we would be remiss if we didn't talk about the impact of COVID-19 on our populations. And I know, Dr. Sterling, you're on the front lines there as a medical doctor dealing with patients. And every week on my show, I have to talk about, for about 2 weeks, when we were in June, heading into July, I didn't, really focus on COVID. It was like, hey, the numbers were trending in the right direction, and, we were near 70%. And then all of a sudden, we just plateaued with regard to vaccinations. And many times it's because of Black folks. I saw this great skit on Saturday Night Live of a Black doctor, and he was talking to his family about why didn't they get vaccinated. Oh, it was COVID, Tuskegee, all of these reasons. But the reality is, Dr. Sterling, is that the overwhelming majority of people that are severely impacted, I'm not talking about the breakthroughs, even with the breakthrough cohort in terms of those that have received the vaccination but still end up receiving COVID, 90 plus, as high as 97% of the hospitalizations are those that are unvaccinated. But yet we run into this brick wall. As my great grandmother used to say, a hard head makes a soft behind.
And what about that surprises you? See, the point to be made here is that let's go back to the original premise here. We can play whack-a-mole and treat after the fact, and some phenomenal efforts, as Representative Kelly said, are being put forth. But we have a sick care system in this country and not a system that honors health prevention and health promotion to the same extent.
Explain that sick care. What do you mean by sick care?
Curative care. You present to an emergency department as your portal of primary care. I'm an emergency physician by training. By the way, these days I spend most of my time working around the world to implement healthcare solutions. But the point I'm making in regards to your question is that if we wait, you've heard an ounce of prevention is worth a pound of cure. It's really just that simple. So if we focus on waiting for disease to present itself to have the system appropriately engaged, instead of dealing with the root causes of what produces disease, then we're already starting out at a disadvantage. And to the extent to which African Americans aren't as represented as the general population in terms of being able to have adequate access to care, we aren't equipped to deal with the cost of care, and we don't get equivalent quality of care. That stacks the deck so that COVID-19 and others like it only becomes a stressor. And when we want to talk about health inequities and disparities, we didn't need COVID-19 to tell us that. The statistic of interest has always been reduced life expectancy. And when we come to the table with a life expectancy 5 to 8 years, depending on if you're comparing males and females, white to black, there's an issue that tells the story in its entirety. And then everything else, whether you're talking about high blood pressure, stroke, HIV, diabetes, stroke, etc., those are simply symptoms of a system that fundamentally misses the mark at the beginning and doesn't appropriately weigh health prevention and health promotion, but focuses more on what to do when disease presents.
There's something interesting that's going on here, Dr. Furr-Holden, in terms of, as an epidemiologist there, that the Affordable Care Act, whether or not people know this, is that it really was focusing on preventative medicine, if I'm not mistaken, in terms of trying to ensure that everyone could see a doctor, not only see a doctor, but afford insurance to see a doctor, thereby when you have that kind of insurance, you don't, and you get your yearly physical, or you actually use a physician as opposed to the emergency room for your primary care, then these disparities are lowered. So it's kind of something that, people always talk about, well, they're forcing me to do something in terms of ACA or Obamacare. But the reality is, when you look at what its main goal was to try to make healthcare affordable by engaging in preventative, real healthcare as opposed to sick care.
Yeah, and I agree with Dr. Sterling. We do have a sick care system. There's much more incentive to treat people than there is to prevent bad health in the first place. And preventing poor health includes many parts of our society that we don't want to address. People have different access to healthy, quality, affordable food. Food is medicine. But oftentimes in communities, the kind of food that people have access to that they can afford isn't health promoting food. It's high calorie, high salt,
Really?
nutrient low food.
So hot links and flaming hots, they're not good for us?
It's not even, it's worse. And I live in Flint, Michigan. Do you know the majority of people in my community use the Family Dollar as their primary food source? You are not going to get whole foods. You're not going to get apples, oranges. I always tell people you need a high nutrient dense diet. The high nutrient dense foods oftentimes don't come with a label. If it's got a label on it, chances are it's not a high nutrient dense food. So yeah, those are not the kinds of health promoting foods, but they're the kinds of foods that people have ready access to and can afford. And the problem that I have with the system is we then blame the disparate. And we say, why don't you all stop eating that food? Not understanding that that's the food that they can get to on foot. That's the food that they can access. And it's the food that's in a price point that they can afford. So again, if we deal with the systems and structures, which is what the equity movement is about, we don't have to blame the disparate and just focuses on differences in health outcomes. But we can focus on what is it about the society, the systems and structures that have these be the logical or best choices for people to make, even though they're not health promoting choices.
How do we reorientate that way of thinking, Ms. Carpenter?
Well, I think we do that by coming together as community. And that, again, is why BDHEA exists. We are a group of experienced healthcare leaders committed in our purpose and approach to advance health equity. And health equity is just what you heard about. It is addressing those social determinants of health, those things that help us as a country to be more healthy. We're positioned, I believe, to bring our blend of expertise and understanding to address structural racism. That's important when you're talking about advancing health equity. It's our lived experience. It's how we come together and partner and collaborate with those who are intentional about helping to solve those inequities that exist. Inequities are most persistent in the Black community. Disparities, gaps have been and continue to be most difficult to close. And that's why partnerships are so uniquely important. And I think that the Black Directors Health Equity Agenda is uniquely positioned through our lived experience, through our roles as healthcare leaders within our organizations to drive an agenda in the boardroom and in the community. We're holding partners, allies, communities, and ourselves accountable to make a difference.
You know, Dr. Emery, when we talk about inequities, there's a sad inequity that exists with regard to the number of Black doctors. I can say, and back me here if I'm correct, or correct me if I'm wrong, but literally, you know, back in the 70s and 80s, there were more, from a percentage perspective, if not even total numbers, there were more Black people going to medical school and becoming doctors than there is today.
Yeah,
And
I
when
agree
we
with you.
talk about inequities, you know, how can you create equality when you're not even on the front lines of the healthcare battle?
Great point, Daryl. And you know, currently about 5% of American doctors are Black and about 2% are Black women. So we're even more of a unicorn, those of us Black women who are physicians. But to your point, it goes to what someone else mentioned, which is systemic racism. You know, there are opportunities for education that lead to someone going down the path of becoming a physician that, you know, there are roadblocks in place. And so I think, as I said earlier, we need to work on every level to address those. We need to address, you know, that on the level of education, on the level of politics. I think, you know, income has a lot to do with it. And these are the same things that contribute to health disparities. Differences in income, differences in, you know, where you live, residential segregation, social and physical environment. So even the violence and the safety issues that affect the neighborhoods in which we live. All of these, it's almost like a vicious cycle, you know, because we live in those areas, those things affect us in terms of our success and going on, you know, to leadership positions in terms of healthcare. And so I think that's something that's very important when we talk about racial disparities in health, that we need to address who is providing that health. I think people are sometimes more likely to listen to someone who looks like them. And I've heard, you know, over the years as a practicing physician, oh, you look just like my cousin, you look, you know, like so-and-so. And, you know, so you build a rapport and there's a trust, you know, that's very important between a physician and a patient. And when coming back to the COVID-19 vaccination issue, I think, you know, that's what we're trying to do. So for instance, Dr. Sterling and I are very vocal on social media in trying to get people to understand what's going on and to alert people to this, you know, rising third wave of the COVID, you know, virus, and trying to get people to get the vaccination. And I think it's important that we have our faces in the place so that people can see themselves in us and think of us as a trusted, trusted person to listen to in terms of health.
You know, as a member of the 100 Black Men of Chicago, as well as building on our national organization, one of their mottos is, what they see is what they will be. And when people get an opportunity to see you, Congresswoman Kelly, as a Black woman, and a member of Congress, or you, Roslyn, in terms of your position, in terms of with your agency, as well as you, Dr. Holden, and you, Dr. Sterling, and also you, Dr. Emery, you know, it expands the opportunities, because they literally can say, oh, wow, you know, that she or he is a doctor, she's a congresswoman, she's a director of a major organization. And I had to chance, Congresswoman Kelly, to speak to Education Secretary Miguel Cardona. And there are so many opportunities out there to literally go to medical school for free. In terms of even NYU, about 2 or 3 years ago, NYU, one of the nation's leading, Dr. Sterling, one of the nation's leading medical schools decided we're not charging tuition anymore to become a doctor because they see the need to become a doctor. What can the federal government do to try to increase these appalling numbers of only 5% of Black male doctors and 2% of Black females becoming doctors?
Well, I definitely think we can look at different programs, but also how many people know that NYU will let people in for free to go to medical school. I don't think enough people know that, first of all, but also the other thing is we have to make sure our young people coming through junior high school and college have the tools they need to even make it to medical school, because it's one thing that is free, but if you don't have the tools to make it, with STEM education, STEM background, it doesn't matter if it's free or if they don't have the support system. I'm married to a doctor, and I know, in his time, the issues that he went through, the lack of support and the money that he owed for many years after he became a doctor. And when I speak to younger people now, when they tell me what they owe, it does blow my mind. But we can, make interest rates lower on the federal level. But also we have to make sure that our young people are prepared and they even have an interest. And it's not just, I don't mean just in that way, but becoming a doctor, there's many other avenues in the healthcare field that people can pursue. Yes, doctor is one thing, nurse, but you could be a healthcare entrepreneur, or there's a lot of different things that you can do.
It goes on and on and on and on. And I just want to, and I know Dr. Sterling, you're chomping at the bit, brother, but I want to go to you, but I only have Congresswoman Kelly just because she has a very hard out. What, in closing, are you optimistic about and also pessimistic about in terms of dealing with regard to this issue of health inequities and health disparities?
Well, I mean, what I'm optimistic about is who we have sitting at the table on the House side and the things we're trying to do, as far as appropriations. We know that more needs to be done, but we're taking steps, for research and funding and helping Black medical schools and things like that. And like I work a lot around maternal mortality and just passed legislation out of my committee on cultural competency and best practices and things like that. And it was, believe it or not, bipartisan, because my Republican colleagues realized they represent some of the states with the worst maternal mortality. So there are some examples of, some good things coming out. Hopefully we can get them passed in the Senate, because that's, lately has been the drag, on everything. But we know President Biden will pass, and Vice President Harris has been very involved with maternal mortality. So I'm optimistic about that. It's still a struggle because there's still institutionalized racism in healthcare, it's systemic, but we just have to keep, we need culturally competent people. I hate that word, but I don't know how else to say it. But, and then also access. Even with the vaccine, we can set it up. But where I live in the burbs, if you don't have a car, you still can't get to it. So, we need mobile vans. We need to go to where the people are also.
Indeed. Well, Congresswoman Kelly, we truly thank you for participating.
Thank you.
Very
good to see you.
Important discussion. I'll be calling on you soon, as always.
Bye-bye, everybody.
Right. And I saw you chomping at the bit there, Dr. Sterling. I know you wanted to add something to that discussion with regard to increasing the ranks of Black physicians. And so please chime in, sir.
Well, actually, I was co-signing a lot of what's been said, but since you offered me an opportunity to do so, I will speak on it. Back in 1989, I actually founded an organization called the Minority Association of Pre-Health Students, and
Wow.
it's in 300 college campuses across the country. So there is an infrastructure in place that's pretty well known in its arena to do just what was discussed. And it's not, you'll note I said pre-health and not pre-medical. So the notion is to improve the pool for public health, for nurses, for physicians, healthcare administrators, and down the line. But as was pointed out, you really have to be ready in your STEM training in order to even get to the point to where you can be pre-med in college. The one other point that I just want to really underscore, because it is such a critical one, public health data has long supported the notion that culturally specific, not just culturally sensitive, but culturally specific providers of services actually produce demonstrably better healthcare outcomes. Okay,
Yeah.
so the trusted messenger paradigm isn't about just a government per se spreading pixie dust and information. It's not about someone acting in the way a missionary would do, for example. You actually have to utilize us, and that's a business proposition, and that's a medical proposition as well. You need trusted messengers to do exactly that. One quick example, my company, Simco, which is a preventive health organization, actually just had a vaccine event on Saturday on 87th Street over at the big mall by the Dan Ryan. And the city of Chicago said, you know, this literally was the best event, that's pop-up event that occurred in 4 months. And it's because we had physicians we had so many people come in with all the typical talking points and concerns, but are being able to diffuse those in real time and provide culturally sensitive and specific conversations, have those conversations with them, was something that really penetrated the psyche of our community, and something that needs to be rinsed, repeated, and done. We'll be doing 2 more in 3 weeks, by the way, but that's just another example of how we need to be given opportunities to drill deep inside of our own communities and promote fixes for ourselves instead of being dependent on others to think they're being generous and giving to us.
Deborah, I see that you wanted to chime in there in terms of agreement and also dispelling those myths as he was able to. One thing that I think happens is that doctors have always held a position, and healthcare professionals, but primarily doctors and nurses, have always held a position of high respect and esteem in our neighborhoods and our communities.
Yeah, and for good reason. And you know, the point that folks are sort of pointing to, and I think what Dr. Sterling and Representative Kelly were starting to point to, is there's a real business case for equity. All of this inequity has a cost, not just
Yes,
the human potential and human capital, but it actually has a monetary cost. And
big time.
equity costs our healthcare system, and it costs our society. A lot of the mistrust that people have, to me, is valid. Really appreciate the work that Dr. Sterling and others, and myself and Dr. Emery and Rosalind, everybody is doing, because the price that we pay as a society is tremendous. But it also is a new era. When Tuskegee happened, and the valid mistrust that people have, not just from Tuskegee, but from modern day wrongdoings, maltreatment, disrespect in the healthcare system, are very real. But I need people to understand, when Tuskegee started in 1932, we had no Black people in Congress.
Yeah.
It was a different day and time. We now have Black, brown, Hispanic, Latin, Native American. Our landscape has changed. And so there is a part of me that's like, how do we do a both and? Capitalize on a grassroots movement, like Dr. Sterling said, where we're not waiting on or counting on something to come up on high, but that we're also holding and trying to do the transformational work to deal with the systems and structures that perpetuate systemic racism and inequity, but also put resources in the hands of community and organizations and people who do the work to move the needle on health for our people. We deserve that. Health is a right. Access to health care is a right, but most of us experience it as a privilege.
Yeah. And not only as a privilege, but a privilege for the chosen few. Rosalind, in terms of the importance of reaching into the grassroots of a community, and how do we do that? Because Dr. Sterling talked about the fact that because of his network of doctors, he was able to have a very successful vaccination event. And I know Dr. Emery has worked tirelessly in terms of Aetna trying to also increase vaccination rates among Black folks and brown people here throughout the state of Illinois. But talk to me in terms of what bona fide measures you have been able to take that truly reaches into the grassroots of a community.
Okay, great. And two points, if I may. I want to go back to representation matters. When you talked about people, people is one of the pillars of the BDHEA. And there are physicians, there's nurses, and then there's bedside staff that definitely impact the outcomes of our patients. And if I can see it, I can be it. So I don't think we could say enough that representation matters, which leads into your question about what can you do and what are we doing? Well, during the day, I'm the Chief Diversity Officer for Common Spirit Health. Really proud, really pleased to share with you about our partnership with Morehouse School of Medicine. We've committed $21 million over the next 2 years as part of a 10-year, $100 million initiative to train a minimum of 300 additional clinicians from historically underrepresented communities. And we're increasing the size of Morehouse School of Medicine student class from 100 to 200, and to triple the number of graduate medical education slots for residency training from 125 to close to 400 over the next 10 years. In my mind, that's generational impact. And Morehouse School of Medicine is led by Dr. Valerie Montgomery Rice, and our BDHEA inaugural summit will be held on their campus September 27th and 28th. For more information, go to www.bdhea.org.
Indeed. Well, it's good to have good news there. And I applaud you. And I saw everybody else doing the hands up signal there. And that's wonderful. But also, I think that in terms of how do you personally, because just picking up on the question that I asked in terms of Rosalind, was that of how do you get this increase also with regard to women? I went to an all boys high school, so I know the importance of being around yourself when you're in an educational situation. I think it helped make me the man that I am today. But Dr. Emery, what else needs to be done to get women involved in this? Because the only way that we're really going to deal with these inequities, of course, is through grassroots movements, but also just like what Rosalind said in terms of investing real dollars into opening up the doors, may have never considered a medical career to do so, and particularly Black women. And it's funny because Black women are disproportionately in college as opposed to Black men.
That's true. That's true. But that points to, some of the, inequities in terms of the medical education system as well. But I think as Dr. Sterling was saying earlier, it's incumbent upon us, those of us who are health professionals and who've made it to this point, to reach back. So organizations such as his that are not only reaching out to the public, but are reaching out to medical students and also reaching out even further, as Representative Kelly said, to high school students, junior high school students, elementary students, and saying, you can do this, and this is how you do it. And these are the obstacles you're going to have to overcome, and setting up real ways to assist them in doing that. Because, it's not rocket science. There are people that are very invested in keeping people from advancing to this point. And so we need to, as a community, come together and say, okay, you're here, you're there, this is what I can do, this is what you can do. Let's do this together, and let's get more people through the door and more people to the place where they can affect change.
And we always want to err on the side of veracity here. So Dr. Sterling has an update, because even though the current position is somewhat lopsided with regard to 5% Black doctors being male out of the total doctor count and 2% being Black female, the reality is that over the last few years, Dr. Sterling, those numbers have flip-flopped dramatically, if I'm not mistaken.
And that's fine if it's a course correction. It wouldn't be fine if indeed the reality of the situation is that Black males have been decimated in a way that reflects our lot in life in our general society. We certainly applaud that. You know, I got to tell you, Black women are as magical in medicine as they are everywhere else in society, and I certainly applaud that. But we have a concern.
They are magical. They are wonderful.
God bless us all for being it anyway. No, but you know, only point I'm making there is that the numbers, to be correct, is just under 5%, not Black males, but 5% total representation.
Exactly.
Positions, and inside of that 2% are Black women. But you know, it's not going to take more than a couple of years before the current trends produce more Black women to where that number will not only be equalized but surpassed. And then we'll be having a conversation about how do we attract more Black men into the system, how do we prepare more Black men to be able to get to the point to be basically. Over the last 10 years, the numbers don't reflect anything like you've seen. It's generational that Black males continue to be a majority of Blacks in medicine. So a lot to do on both fronts. These aren't mutually exclusive. We need to elevate the entire pool. And that's an even more important point. If we increase the pool up from 5% to something that's more representative of society, then we would be doing better regardless as to the proportion of men and women inside of that.
That is a long road to hoe, because when you take into account we're at 5%, and included in that 5% is 2%, but with a growing population of women there, how do we get to 10 or 12%, or in some cases 13%? Because many times, in terms of on our Latinx side, I think that there are a number of Afro Latinx that, you know, fall into a different category than identifying as African American. Rosalind.
For meaningful change to occur, we must address the causes of health inequity. We've got to identify and remove those barriers to health, and we must partner, and collaborate at every social level possible. You know, we're not healthy until everyone is healthy, and we cannot have a strong economy or country if health inequities and racism persist. I believe that together we can have a brighter future, but we must act, and we must act now.
You know, I want to bring the conversation as we get ready to close out here back to Dr. Furholden, in terms of where do we need to put the majority of our energy in terms of reorientating the thought processes of people that are reluctant to take this vaccine?
Well, so I think we've got a couple of things. I love the conversation around representation. It's an important one. We've now learned that the role of the trusted, credible messenger is unparalleled. And I want to be clear, it's not just Black and brown people who remain hesitant. The lion's share of our hesitant population to get this vaccine are actually not Black or brown. They're conservative white men.
Yeah.
And so representation matters. So we need the trusted, credible messenger. To increase that pipeline, we got to deal with pipeline. Getting to and through medical school, getting to and through a graduate program in social work or public health and all of that. If we're trying to resolve that problem at the level of college, we've waited too late. We need to make sure that our babies, from the time they enter into school, from the time that they go into pre-K and early childhood and Head Start and all of that, we know for a fact that talent and brilliance is prevalent and dominant in our community, but opportunity is not. So if we want to deal with representation, we got to make sure that we provide those opportunities for people so we can start pipelining them from the womb. And as far as this issue around equity I believe in that. We got to start equity and pipeline from the womb.
Whoever's pregnant out there, you know, talk to that baby. You are going to be a doctor. You are going to be an engineer. You are going to.
Because we need the credible messengers. And I'm about to be a grandma. I have my first grandchild coming in 4 weeks from today. So it's an interesting thing, because having this conversation with my Generation Z daughter, I had to explain to her, you know what? The COVID virus will cross the placenta. So if you can track COVID, you will likely give your unborn daughter COVID. As well, the COVID antibodies will cross the placenta. So if you get the COVID vaccine, you'll also be giving your baby COVID antibodies. We need the trusted, credible messenger at all ages, at all stages, to get the word out so that our people who, while we might not be the largest representation of the vaccine hesitant or in the population, Black and brown people, people of African ancestry will be important in helping us get to this thing called community immunity and herd immunity. The role of the Black doctor, the Black pastor, the Black trusted credible messenger is unparalleled, not just in COVID, but in all things health, health equity, and racial equity. So I salute the work of Roland and BDHEA, all of that. Dr. Emery, Dr. Sterling, Representative Kelly, we need it in all sectors of our society to pull it all together so our people can hear the word from people that they trust, that they should trust. This is not the era of Tuskegee. What happened in Tuskegee was horrible, but we have a very different landscape now. So we need trusted, credible messengers to shore up the confidence of our people in health and healthcare.
Yeah, and in some ways, it's almost like mixing apples and oranges, Dr. Emery, because when we look at Tuskegee, and it's the power of truth and the power of information here. Nobody was given something. What happened was that they had individuals, and correct me if I'm wrong here, that actually had syphilis. And even though there was a treatment in terms of penicillin for those individuals, they never gave it to them. They never gave them the treatment.
Correct. And
nobody was infected with it. And likewise, how do we dispel these prevalent myths that are out here? I heard Dr. Ngozi Ezike say, I asked her the question, well, people say, well, you're injecting me with something to monitor my whereabouts. She said, what are you talking about monitor your whereabouts? This right here monitors everything that you do. I'll tell you what you want.
That's right. That's right. No, and you bring up a great point. I mean, this is what we're combating. We're combating, misinformation, and especially in the age of the internet and with social media. I mean, there are so many, terrible things out there that are giving people the wrong information. And so, to Dr. Verholden's point, making sure that you're getting your information from the best places. So, the CDC's website, IDPH's website. We want to make sure we're getting the correct information and we're not just going by what someone said on Facebook, because that may not be correct. And I think, they're going to be, in the end, we're going to look back and we're going to say there are certain people politically and, in the media that have blood on their hands because they, put out all of this misinformation. And as a result, hundreds of thousands of people died. And so I think it's very important that we make sure that we flood social media and the airways and all media with information like this, like that you're providing today, which is correct information, which is the truth, because that's what people need to feel comfortable. They need to know the truth. They need to feel that they have all the information they need to make the best decision for themselves in terms of getting vaccinated.
Yeah. Rosalind, how do we make sure that truth is paramount and that is what we're hearing? It said that no one should get their news from Facebook. I'm just being honest as a journalism because it's going to cause an assault on freedom of the press if we keep going down this road where people that aren't qualified have platforms and mouthpieces to spew untruths and rhetoric that really causes people to die.
I agree. And, another effort that I'm involved with is called the NCRN, which is the National COVID Resiliency Network. It is an Office of Minority Health grant that was awarded to Morehouse School of Medicine. And they're going around the country mitigating the impact of COVID. Much of that is about disseminating good information. It is about having town hall meetings. And to answer your question, you go where people live, work, play, and pray. And you give them the good news. You tell them, get your vaccination, save your life, save the life of those that you live and love with. We cannot not share the good news, which is there is help. We know that COVID will kill you. We know the vaccination will not. Take the vaccination and live a better life.
Dr. Sterling, I really want you, and then I'm going to go around the horn to give everybody a chance to make a closing brief statement, but I need you to be in a sharing mode. what specifically did you employ that made your vaccination event successful? Because this is about helping our entire community that are watching this in terms of the 55th annual Rainbow Push International Convention. We want them to be able to share what it is that you found successful that they can implement through their own organizations to arrive at a similar success, so that way we can see these vaccination rates grow exponentially among the unvaccinated.
Two take-home messages in particular, and let me go in the Wayback Machine, back to the Ubuntu tribe. I am because we are. There was a time in which, as was mentioned during Tuskegee, where there were no Blacks to serve as the wall against the nefarious efforts of those researchers. There has been a lot of effort. A lot of it's been invisible, but you now actually have individuals. You have great representation in many different forms on this in this conversation right now. And understanding, having a conversation with the resistant, where they realize that I am here for you, I am a product of you. If this indeed was what you thought it would be, I would literally be the one sounding the alarm. That is a level of trusted messenger that we have to engage in. And the corollary point to that is that we have to stop this broad stroke approach to our initiatives, and we have to get engaged in hand-to-hand combat. We have to fight for one life at a time inside of our community. And the difference that we can make in saving one life at a time could literally produce individuals such as the individuals that serve on this panel. We have to care enough and to get in the weeds, get back into our communities and not trust the governmental, well-performing entities, but we have to assume the responsibility based on the work and the blessings that we have received. So whether you call it, moving it forward or paying it forward or whatever the case may be, I really think that the work that you can do, taking care of one person at a time over an extended period of time, can really transform things to where 6 months from now, a year from now, you now have a different set of conversations. And like I said, this is now 30 years ago that MAPS was founded. As bad as the data is now, can you imagine what it wouldn't be if there weren't these organizations on 300 college campuses across the country? What we do as individuals and as a community matters. So I look forward to continuing the collaboration with Dr. Emery and working with everyone else here to find solutions while we all perform in our own individual ways, but do not discount the difference that each of us makes to those individuals that haven't been blessed in the way in which we are in our communities.
Yeah, so one key was that literally touching base with everybody within what I like to call your sphere of influence and said, come on out.
We literally positioned ourselves in a huge parking lot. I mean, there were 1,000 people in every direction, from the Jewel Osco Grand Bazaar to the Home Depot, et cetera, et cetera. And we deployed several dozens of individuals into those parking lots just to have conversations. We literally got in their face and went into the stores with permission from the local aldermen and the local store managers and said, look, you have concerns. We have several physicians over here. Come have a conversation with those doctors. They were willing to do that, and we were able to dispel those notions in real time and get them to where they needed to be. That's the effort. It's not always going to be successful, but it's better than the alternative.
30 seconds, Dr. Fur Herman and Holden, in terms of how we get rid of these disparities and inequities.
All right, great. So we got power. I say we use it. I love the notion of we can do a both and, the grassroots effort and the higher level. I love that we got Congress represented in this conversation. I'm calling for a mandate for equity. If it matters, let's just consider our society got baked without equity in the cake. So imagine if you baked a cake and you forgot the sugar. You can't just sprinkle it on after the fact and expect it to taste like a cake. We got to do the work to get equity now baked in. And I think that we can do that. And a big part of that, I love the work that Dr. Sterling is talking about. We've done very similar grassroots efforts in Michigan. We were the first state to close the racial disparities gap in COVID cases and COVID deaths. That's because we matched the level of the solution to the level of the problem. It was both grassroots, it was also policy, it was representation, it was all of these things happening at the same time. So I say we have to keep doing that work, hold our elect leaders to account, and get resources where they're really needed. We are the best people and the best messengers for our people. and we need to be resourced to do that work.
Indeed, that is from a Michigan Spartan. Go, 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 Michigan.
Go green. Go green.
Rosalind, final comments here.
My final comment is twofold. One, get your vaccination. Reach out to your neighbor. That's how I got my vaccination. I was scheduled to drive to Chattanooga to go to one of our Common Spirit Health hospitals that Monday. Well, that Saturday morning, I got a call from a dear friend. I'm on the health policy board at Meharry Medical College. And the call simply said, look, we're doing an outreach Saturday. Come down and get your shot. And I said, well, scheduled for Monday. And they said, no, you need to come down here. We're giving out shots today. I said, well, you know, it's Saturday morning. I'm doing self-care. I need to do my hair. Said, hey, put on a hat and come down here and get your shot. And it was a beautiful thing. You saw adult children rowing in their grandparents and their parents to get shots. Their president of Meharry, Dr. James Hildreth, walking around, making sure people were comfortable. You talk about HBCU, you talk about culturally competent care. It was so present. Reach out to your neighbor, make sure they have their shot. Secondly, participate in the Black Directors Healthcare Agenda Summit, September.
Give us that web address.
The web address is www.bdhea.org. Thank you again for having us.
That sounds so very good. Dr. Emery, you have been tireless during this COVID dilemma that we're going through. And what would you like to say? Because Aetna has done so much in the state of Illinois, particularly the Chicagoland area.
Well, I think, again, and echoing what people have said, it's about all of us doing this together. So currently we're collaborating with the other MCOs in the state as part of the state's All in Illinois project. And so we have events coming up, so you can look for those on the state website. We also have shifted our focus to being hyper-local. So instead of having mass vaccination sites, as many of us know, most of those in the state have closed, we're looking at how we can bring the shot to you, how we can go into someone's home and get them the shot, how we can tell them to go to their local pharmacy and get the shot. We want to make sure that the shot is ubiquitous, that it's everywhere, that you can't, go to the grocery store without someone bugging you about getting it, as Dr. Sterling said. So that's really been the shift in our focus is bringing the vaccine to where people are, to give that access so that people have the ability, if they make that choice, they can get it right then and they don't have to look for it. Because that's really what it's going to take to get us to herd immunity and to the point, where the virus is not interfering with our lives and where we're not having these, upticks and surges, going back to masking. There's a lot going on in terms of the whole masking debate. But, it looks like we're really losing at this point, and we really need to all come together and really concentrate our efforts on getting everyone we know vaccinated and making sure that we're behaving in a safe way.
Dr. Sterling?
I'll be quick. Two things. The work that we're doing, at some point in time, we're going to have to start talking about how to make our community known for health. We have to transform the way in which we view health in our communities. An ounce of prevention is worth a pound of cure. We're going to have to start to take responsibility for health prevention and health promotion inside of our communities so that we aren't known for healthcare disparities and premature death on the back end. This is a long-term conversation and project that is very meaningful to me and everyone else on this call. So thank you for hosting. You're the perfect person to have hosted this forum, and thanks to Rainbow Push for bringing it to fruition. So thank you. Thank you for having me.
And how can people find out about that tremendous work that you're doing?
Go to thesimcosolution.com.
Sounds so very good. I want to thank all of our participants today. Please take advantage of their website as well as them individually. They are giving individuals who are tireless in their effort to make sure that every inequity and every disparity no longer exists. I want to thank you for joining us for this panel discussion. Please stay tuned for more from the 55th Annual Rainbow Push International Convention. I'm Daryl Denard. Thank you so much, everyone. Have a great day.